Good morning and welcome. My name is Rita Boltron, and today I'll be discussing experiential learning and clinical debriefing, along with its relativity and impacts on professional practice as a paramedic. In addition, I'll also be reflecting on personal experiences whereby experiential learning and clinical debriefing have manifested in my practice. To gain a fully comprehensive understanding of experiential learning, learning styles must first be explored. Learning characteristics that possess and influence the learning process are described as learning styles. Itself is not an ability, but merely a preferred method of utilizing one's learning ability. Individuals will possess different learning styles, which differs in their inherent behavioral and preferred method of processing, absorbing, and retaining newly acquired informations and skills. There are numerous theories that are suggestive of a great diversity of learning styles, one theory being the modality theory. The theory recognizes four different styles of learning. Firstly, the verbal or visual style. Learners who utilize this form of learning possess greater efficiency upon the presentation of visual information in written modality. They benefit from lectures with photographic and written content. In addition, they excel in textbooks-based learning, supplemented with other written or photographic material. Secondly is the visual or nonverbal learning style. Learners with this style are proficient in utilizing visual information in the modalities of pictures, textbooks, diagrams, instructive illustrations, as well as videos. Their learning is primarily driven with the utilization of visual aid to assist in the conceptualization and acquisition of skill and knowledge. Thirdly, the auditory or verbal learning styles. Learners who execute this form of learning utilizes auditory or verbal information primarily conveyed through speaking. They also benefit from lectures and group work such as discussion and debriefing, also problem-based learning. The acquisition of skill and knowledge can be further reinforced with audio tapes, podcasts, and verbal repetition. Lastly, the kinesthetics or tactile learning style. This learning style involves the performance of a skill and application of the learnt knowledge in a hands-on manner. Learners with this learning style excel in practical activities, utilizing the knowledge and skills they have learnt and put it into practice. They supplement the learning by undertaking scenario-based activities, simulations, and other tactile materials. Let's take intravenous cannulation as an example. It is a skill requiring the delicate insertion of a cannula into the vein guided by a needle, in an effort to convey the information in a way that facilitates the learning styles of others. Cannulation was taught as such. So firstly, verbal or visual learning styles was facilitated with the use of text and written information such as from the QAS clinical practice procedures of peripheral intravenous cannulation. Secondly, the visual or non-verbal styles was accounted for the usage of diagrams from the QAS CPP as well as additional visual aid. Thirdly, the auditory or verbal learning styles was catered through verbal instructions with consistent questionings of factors involving intravenous cannulation. Lastly, the kinesthetics or tactile style was delivered through using a cannulation arm, whereby the notions and the movements of the skills are applied. All inputs of the modality learning style theory can be seen in action upon the delivery of the content. In their own time, the learners are expected to internalize what has been delivered and further reinforce their knowledge and skills through their own means. Though these learning styles provide the basis of conceptualization of knowledge and skill acquisition, these styles are somewhat deficient and doesn't account for other variables as such that would be evident in the reality of practice. For example, upon learning about cannulation, it is known that patients will experience pain and some form of discomfort. The unsteadiness of hands, perceived feelings, the texture, and the integrity of the skin by different patients, the way these patients will respond, and what to say to them is somewhat not accounted for while learning cannulation. And hence the requirement for experiential learning. What is experiential learning, you ask? Experiential learning is a learning style that utilizes the execution of a skill or task under the premise of subjecting the individual to experience the action itself. It is a unique learning style as it enables the individual to obtain immediate feedback from perception, cognition, and awareness of the skill that they are executing, as well as the surrounding environment. In other words, it can also be described as experience acquired from a workplace that is concurrent with education and delivery of real-life services. It is widely utilized in the clinical sphere with its usage spanning from the most novice clinicians to specialists in their own field of practice. Again, let's take cannulation as an example. So it was taught to me in a controlled indoor environment using a plastic cannulation arm. In clinical placements, I had to cannulate a septic elderly patient with tough skin in the back of a moving ambulance. With experiential learning, I was subjected to recognize the depth, the dimension, the temperature, the skin integrity, the texture, as well as the color of the cannulation site, the patient's response, as well as the decrease in feasibility while cannulating in a moving ambulance. So despite the untimely cannulation and being inexperienced in cannulating in a moving vehicle, I was able to get the cannula in, as experiential learning has subjected me to experience that particular event. In future practices, if I was to cannulate a patient with similar skin texture and integrity, I now know how much pressure to deliver when cannulating so that I can execute the skill in a timely manner. Experiential learning is important as it is a key foundation of self-growth, whether it is a growth in confidence or a growth as a professional and a clinician. It is a learning style that will be undoubtedly executed in great frequencies, especially upon transitioning from a student paramedic to a graduate paramedic. Factors that will be subjected for experiential learning will involve the clinical, social, as well as the operational aspects of paramedic practice. Upon handover to the hospital and completing the case, my mentors agreed that it wasn't an ideal condition for cannulation and commended me for getting the cannula in. And they've also advised me that I'll be better with more experience in similar conditions. So the entirety of the case, along with its details and prospects for future management, were discussed in a casual manner. So this is a form of clinical debriefing. The reciprocal exchange of contextual information that is undertaken in a collaborative manner between two or more persons is a process defined as debriefing. Through the synthesis of an environment that is free from negative judgment and bias, reciprocal questioning and mutual analysis can proceed to attain a comprehensive understanding of the scenario or the case. Now, debriefing is applicable and is widely utilized in the clinical context, which also extends to encompass paramedic practice. From a conversation in the car or being in a conference room with case notes, patient data, and laboratory results utilized for the purpose of discussion, clinical debriefing can occur almost anywhere. It is undertaken to gain a comprehensive understanding of the case nature, to identify any deficits in knowledge, and to provide the opportunity to impart knowledge onto others. In a way, it is a form of reflective practice, being an active in nature, engaging as well as involving others, rather than self-reflecting in solitude. In paramedic practice, though it is not a process that is formally planned and organized, clinical debriefing does routinely occur after all the majority of cases. The debrief can explore a multitude of factors such as the feelings perceived from the case, the patient presentation, alternative treatment plans, strengths exhibited, weaknesses, and potential strategies for improvement. During clinical placement, there was a case that was attended whereby the patient presented with shortness of breath and increased work of breathing, and on examination, full field expiratory and inspiratory wheezes, low oxygen saturation, hypertensive and tachycardic. The patient possessed no significant respiratory or cardiac history, as well as no extensive medication history as well. So the crew then decides to treat for severe bronchospasms with salbutamol, ipratropium, high flow oxygen, and adrenaline. The patient initially responded to the treatment for a protracted period and then further on manifested coarse crackles. The treatment plan was then altered towards treating for acute cardiogenic pulmonary edema, with a HARU arriving on scene as backup. Upon the completion of the case, the crew discussed how well the case was managed, not recognizing APO, and placed some strategies for improvement. The HARU was very professional to facilitate a more extensive clinical debrief, whereby the pathophysiology of acute cardiogenic pulmonary edema and asthma was undertaken, the mechanisms of the pharmacological interventions that we provide, the patient's presentation, along with reciprocal questioning and constructive feedback. Personally, I believe that clinical debriefing is an excellent tool that complements my learning and serves as a means for skill refinement and error rectification. The feedback that is attained is internalized and processed. In doing so, future or similar case presentations can be managed in a manner that is efficient, precise, timely, and safely. In future paramedic practice, it is likely to encounter challenging cases that will require a debrief to gain a comprehensive understanding and to reflect upon the case, concurrently outlining any strengths, weaknesses, and to generate strategies for future improvement. Overall, it really provides a learning platform to further the development as a professional and as a clinician. So the take-home message today is really that the modality style theory recognizes 4 different learning styles, and that experiential learning is a unique form of learning style that utilizes the execution of skills or tasks under the premise of subjecting the individual to experience the action itself. It is a learning style that will undoubtedly be executed in great frequencies, especially upon the transitioning from student paramedic to a graduate paramedic. Clinical debrief is undertaken to gain a comprehensive understanding of the case nature, identify any deficits in knowledge, and to provide the opportunity to impart knowledge onto others. In paramedic practice, though it is not a process that is formally planned out and organized, clinical debriefing routinely occurs after the majority of all cases. In future paramedic practice, it is likely to encounter challenging cases that will require a debrief to gain a comprehensive understanding and to reflect upon the case itself, concurrently outlining any strengths, any weaknesses, and strategies for future improvements. Overall, it provides a learning platform and to further develop the development of a professional and as a clinician. Thank you very much for listening.